Well, here we are back to talk about Chapter 54, which is the anemia drugs. In order for us to talk about anemia, we need to touch on a couple of other concepts. Hematopoiesis. So hemato is blood. Poiesis means formation. So in simple words, it's the formation of blood. And we know that there's the formation of new blood cells. So we have our red blood cells, our white blood cells, and our platelets. Also are called erythrocytes, leukocytes, or thrombocytes. At birth, the cavities of all of your bones were filled with hematopoietic or blood-forming elements. The bone marrow is extremely cellular with very active red hematopoietic marrow and very little inactive yellow fatty marrow. But with age, the bones and their cavities grow, so the extra space becomes actually filled with this fat, and bone marrow cellularity actually decreases and fat replacement increases. So after about 4 years of age, hematopoiesis diminishes within the shafts of the long bones, and by the age of 25, except for lymphopoiesis, and we know about the lymphocytes, right? That the hematopoiesis is confined to the flat bones and the pelvic area. So you probably remember from your reading or from biology that your red blood cells are manufactured in this bone marrow. All hematopoiesis derives, the cells are derived from this pool of undifferentiated cells, the stem cells. And that gives rise to the bone marrow cells by their proliferation and their differentiation. So our immature red blood cells are called reticulocytes, and their lifespan is about 120 days, 90 to 120. So the term for red blood cell formation is actually erythropoiesis, right? That's the process which produces the red blood cells. And so we have our red blood cell that starts out as an immature cell in the bone marrow. After about 7 days of maturation, it's released into the bloodstream. You may remember that this is controlled by a hormone called erythropoietin that is produced mainly in the kidney. Now, more than 1/3 of a red blood cell is made of hemoglobin. Heme is the red pigment that contains iron, and globin is that protein chain. So here's a little fun factoid for you. The visible absorption is what makes that hemoglobin red, and the red color arises from the differences between the energy levels of the d orbitals around the ferrous atom. So there's an energy difference between them, which determines the size of the wavelength of the absorbance, and that's what gives it its red color. So remember, any decrease in erythrocyte count, whether it is because of the lack of cells or the loss of cells, is called anemia. So we can have anemias from 2 different ways. We can have it because there's a red blood cell maturation defect, or we could have it because there is an excessive red blood cell destruction. Maybe with the red blood cell maturation defect, we have some sort of a membrane disorder. There could be an enzyme disorder, so it could be cytoplasmic or nuclear. It could be that there's a hemoglobin synthesis disorder. With our excessive destruction, there can be an intrinsic problem or an extrinsic problem. So the intrinsic problems could be things that are destroying the red blood cells internally. And then our extrinsic mechanisms are things like mechanical trauma, chemical injury, infection, or an immunological injury. So this is a brief visual of the cytoplastic maturation defects that can occur. You may have decreased iron ingestion or decreased iron absorption, or there's decreased iron transport from body storage sites, which leads to a decrease in the hemoglobin synthesis. We could also have a genetic disorder like thalassemia genotype, where we have decreased hemoglobin synthesis. And because of that, our red blood cells, cytoplasmic maturation doesn't occur as it should. So there's a red blood cell cytoplasmic maturation defect. And as a result, we see a consistent iron deficiency anemia and expression of that genetic disorder, that thalassemia, the thalassemia phenotype. When we have a nuclear maturation defect, that should have another E in there, we have our vitamin B12 deficiency, our folic acid deficiency. Remember, those two typically go hand in hand. So our red blood cells nuclear maturation is defective, and we get what's called a megaloblastic anemia. So here we have a group of this megaloblastic anemia. We have this disorder where we have a reduced rate of DNA synthesis. And so as a result, we end up with our pernicious anemia secondary to our vitamin B12 deficiency and a folic acid deficiency anemia. Now, these are not the only types. That's not the only type of the cytoplastic maturation defect or the nuclear maturation defect. These are just examples. We can then have anemia from excessive destruction of the red blood cells. So with intrinsic factors, things that occur that destroy the red blood cells more rapidly than usual are things like sickle cell anemia, hereditary spherocytosis, or G6PD deficiency. G6PD being an enzyme that is required to make the red blood cells, to make the heme be processed. So G6PD is like both sickle cell and hereditary spherocytosis, is a genetic disorder. As a result of this increased red blood cell destruction, then we have a hemolytic anemia. Extrinsic factor examples are things like drug-induced anti-red blood cell antibodies, or we have maybe a pancytopenia. We can have a septic shock where we have disseminated intravascular coagulation. We'll talk about that in more detail when we talk about the anticoagulants. Also, certain medical devices, like some of the older cardiac valve implants, create a situation where they destroy red blood cells. So that can lead to this increased red blood cell destruction and then subsequent hemolytic anemia. So we have the erythropoiesis stimulating agents, our Epogen alpha, also called Epogen. This is a biosynthetic form of the natural hormone, that the erythropoietin that's made in the kidneys primarily. It's used for the treatment of anemia associated with end-stage renal disease, chemotherapy-induced anemia, and for anemia associated with zidovudine therapy. You may recognize zidovudine as a Retrovir. It's a HIV type 1 drug. Then the Epogen is actually a longer-acting form. There is a longer-acting form, called darbepoetin, Aranesp. With these drugs, the contraindications include, of course, a drug allergy, if we have uncontrolled hypertension, any head or neck cancers, remember what happens with cancer and blood, and the risk of thrombosis. If they have a higher than usual risk of thrombosis, then we wouldn't want to stimulate the cells to create those red blood cells. So, of course, you remember that the heme, the iron, is essential as a mineral that's needed to form that hemoglobin. That's the oxygen-carrying protein that's inside the red blood cells. So iron deficiency anemia is when we have a condition where the body doesn't have enough of the iron so that it can't create this heme. Iron is actually stored in the liver, the spleen, and the bone marrow, but when we have a deficiency of it, then we have iron deficiency anemia. And we can see that we also can have this is the most common form of anemia. It develops over time if you don't have enough iron, or if you don't have enough iron stores. So once your iron store is depleted, the body is actually able to make very few red blood cells. So if erythropoietin is present without sufficient iron, then there's not the fuel that's needed for the red blood cell production. So it just kind of becomes cyclic and gets worse and worse. And then the red blood cells that the body is able to make are abnormal, so they don't have that hemoglobin carrying capacity. Now, iron deficiency anemia can be due to blood loss, but it's often due to poor diet or the inability to absorb enough iron from the food. So what are some of the foods? Well, dietary sources include our meats, certain vegetables and grains, and dietary iron must be converted by the gastric juices before it can be absorbed. So even if you have enough iron in your diet, if you happen to have an intestinal surgery or a disease of the intestines, then it could be that there isn't enough ability to absorb enough of it. There are some prescription medications that also can reduce the acid in your stomach, which can interfere with iron absorption. We want our patients to try to get enough in their diet. So we also need to have, if they're going to take an iron supplement or they're going to have iron increased in their diet, we want them to take that supplement with orange juice. Veal, fish, and ascorbic acid increase or enhance iron absorption. Foods that impair iron absorption include eggs, corn, beans, cereal products that contain phytates, as well as milk and dairy products. So do not inform your patients, do not take that iron supplement with a glass of milk. It'll inhibit the absorption. Supplemental iron can be given as a single drug or part of a multivitamin, and oral iron preparations are available. These are the most common, so we can have a ferrous fumarate, a fumarin, a ferrous gluconate. That's very common, and the ferrous sulfate is even more common. The parenteral forms, we've talked about the dextran and the iron dextran. This is an IV form. Iron sucrose or the Venafir is a much easier tolerated parenteral form. Then we have ferric gluconate and ferrimoxetol. The obvious indication for iron is the prevention and treatment of iron deficiency anemia or iron deficiency syndromes. Administration of iron alleviates the symptoms, but we still have to correct the underlying cause of the anemia. Otherwise, it's just going to return. The most common effects or adverse effects are GI upset, and iron overdose is actually the most common cause of pediatric poisoning death. So we want to be sure that patients know to lock those up. Even those multivitamins with iron need to be locked up, safe away from the small children. Again, most commonly you're going to see GI upset, and they do cause black tarry stool, so make sure your patient is aware of that. If they're taking a liquid preparation, it will stain their teeth or can stain their teeth, so they should take that with a straw. Injectable forms are given Z-Track. They cause pain. They are very thick and viscous, and so need to be given in a deep muscle. Iron toxicity symptoms, we will do symptomatic and supportive measures. They're going to see iron intoxication. We'll see coma, maybe shock, seizures. They'll need chelation therapy to remove that heavy metal. And we often use a medication called deferriprone, which is used when we have iron overload. They're going to need correction because they're going to end up in acidosis, and we want to control their shock and dehydration. So we're going to take a quick break and do a part 2 for this audio lecture on anemia drugs. See you in a minute.